Good afternoon, everyone. I'm Kate Blackman, and I'm a program manager in the health program at NCSL. On behalf of the National Conference of State Legislatures, I would like to welcome you all to today's webinar, State Approaches to Addressing Health Disparities. Before I introduce today's fantastic panel of speakers, I want to thank the Association of State and Territorial Health Officials and the Office of Minority Health for their support and partnership on today's webinar. I also want to let you all know that today's webinar will be recorded and will be available on the NCSL website by next week as a video archive. We're so glad to have you here today to learn about and discuss health disparities and state strategies to reduce them. After a short welcome and background on NCSL and our partners at ASKO, we will dive into the issue of health disparities, the burden of inequities, the factors that contribute to disparities, and the associated financial and human costs. Then we will have the opportunity to explore two states' approaches to addressing health disparities in the legislature and the Department of Public Health. There will be time for Q&A and discussion at the end of the presentations, and you can ask questions at any time during the webinar. Please enter your questions in the Q&A box, which is in the bottom left-hand side of your screen. If you would like, you can specify which speaker you're addressing your question to. I will read the questions and ask speakers to address them again at the end of their presentations. The slides are also available to be downloaded in the media library, which you can access near the top right-hand part of your screen above where you're seeing the slides now. You click on the icon that looks a little bit like a piece of paper or a rectangle with the play symbol in it, little triangle shaped symbol right in the middle, and you can download the slides there. First, I'd like to provide a bit of background about NCSL. NCSL is a bipartisan membership organization of state legislatures. Our members are all 7,383 state legislators and more than 30,000 legislative staff in all 50 states and the territories. NCSL seeks to support state legislatures and promote innovation and communication between state policymakers. We provide research, education, and technical assistance. Our state policy staff is based here in Denver, Colorado. We cover every policy issues that legislatures touch, including topics like education, human services, transportation, energy, environment, health, criminal justice, and more. We also have an office in DC that works on federal policy and provides a cohesive voice for the states at the federal level. I would also like to remind participants that NCSL does not advocate for any specific policies, nor do we take a position on state issues. This webinar is one of many platforms that we provide for information exchange. NCSL's health program has been working on issues related to health disparities for many years in partnership with the Office of Minority Health. We've convened meetings, provided technical assistance, and since 2010, tracked legislative activity on reducing health disparities. In our legislative tracking, we've seen anywhere from 50 to upwards of 80 bills introduced each year. Some of the trends we've seen relate to strategies to increase access to health care services and ensure a diverse health workforce, convening task forces or other groups to examine health disparities and related issues in the states, and recognizing disparities in the role of the social determinants of health. This map depicts state activity, states that introduced and enacted bills related to disparities in 2015 and 2016. It is part of a forthcoming policy brief about state strategies to reduce health disparities, which will be available for free on NCSL's website in the next week or so. I would now like to introduce and welcome Claire Rudolph, Director of Health Equity at the Association of State and Territorial Health Officials. Thanks again to ASKO for partnering with us at NCSL on this project and this webinar. Claire, I'll turn it over to you.
Thank you, Kate. Hi, everyone. I'm Claire Rudolph, the Director of Health Equity at ASKO. ASKO is the Association of State and Territorial Health Officials, and we are the national nonprofit organization that represents the public health agencies in states and territories across the United States, including our U.S. territories, freely associated states, and District of Columbia. Our mission is to transform public health within states and territories to help our members dramatically improve health and wellness. Next slide. And this is just a visual representation of our membership. Next slide. So health equity and advancing optimal health for all people is really a cornerstone of all of the work that ASKO does, because we believe that public health is uniquely positioned to address avoidable inequities for all groups, especially those that have experienced socioeconomic disadvantage or historical injustice, so that all people and communities can feel empowered to achieve the highest level of health. And we do this through a variety of ways, including building the capacity of state and territorial health agencies and supporting our members to communicate the value of health equity and public health. We provide technical assistance, support with strategic planning, we convene meetings, and create and distribute resources and tools for our members to support their health equity efforts. Last year, Dr. Ed Ellinger was our member from Minnesota, and he was ASKO's president. He issued a President's Challenge on health equity, which was focused on the triple aim of health equity, which is illustrated here. We are so thrilled to support NCSL in this webinar and their work to support state legislatures in advancing health equity. Thank you.
Thank you, Claire. I will now introduce our speakers for today's webinar. We're thrilled to have them joining us today. First, we will hear from Siobhan Arline Bradley. Siobhan Arline Bradley is the Director of External Engagement for the Office of the United States Surgeon General. Mrs. Arline Bradley has over 17 years of public health experience and is a nationally sought-after public health expert. Southern New Jersey native, is a public health advocate and former track and field athlete who earned her Bachelor of Science degree in exercise physiology and Master's of Public Health degree from Tulane University in New Orleans. Mrs. Arline Bradley received her Master's of Divinity from the Samuel DeWitt Proctor School of Theology at Virginia Union University in Richmond. Our next presenter will be Senator Jim Abler. Senator Abler has served in the Minnesota legislature for 19 years in both the House and the Senate. In the Senate, he is a member of several committees and currently serves as the chair of the Senate Human Services Reform, Finance, and Policy Committee. Senator Abler has also been a practicing chiropractor for more than 35 years. Finally, we will hear from Sarah Hernandez. Sarah is the Director of Policy in the Colorado Office of Health Equity at the State Department of Public Health and Environment. In this role, she implements a health and all policies approach to design strategies for addressing complex social factors that create inequities. Sarah has led projects focused on early childhood initiatives, program evaluation, policy change, and is actively involved in several health equity initiatives related to policy, data, and workforce development. Sarah holds a Master's of Public Health degree with a concentration in Community and Behavioral Health from the University of Colorado at Denver. And so I will now turn it over to our first speaker, Siobhan Arline Bradley, for a discussion about health disparities and health equity.
Thank you so much, and good morning to some and good afternoon to others. It is a pleasure to serve today as one of your panelists. I'm really excited about the conversation on how to make it make sense. Health disparities is a conversation for those of us that are in public health. We have it all the time, but when we have an amazing opportunity to share with leaders in state houses and general assemblies across our country, this is an opportunity that gives us a chance to walk through some of the basics of health disparities and, quite frankly, the major role that policymakers have in achieving some of these goals. And so I wanted to have a little bit of fun. One of the things that we find in this work in health equity and health disparities, sometimes people have no idea what we're talking about. They hear the term and they know that it means something, but today we really want to kill the myths and give you a real definition of disparities and our ultimate goals of equity. And so health disparity, it's a particular type of health difference, and health difference is underlined in that it's connected to socially or economically disadvantaged populations. Health differences are measured based on health outcomes. So there are differences in disease state, differences in economic access, differences in social experiences. And the second bullet point is really, really important to gather. When you look at specific groups, people who have systematically experienced long-term obstacles in economics, long-term health obstacles, and quite frankly, long-term environmental obstacles. These are solely based on the following things: race and ethnicity, religion, socioeconomic status, gender and age, based on mental health or cognitive, sensory, or physical disability, sexual orientation, geographic location, and other characteristics that are historically linked to discrimination or exclusion. And I want to stay on this slide just for a second to give you a cross-section of what we mean by some of these long-term historically linked discrimination or exclusion experiences. If you look at the list that's presented to you, we can all think of groups of people in our country and even across the world that have been discriminated against or have experienced long-term difficulties in one of these areas. And as state legislators, what is really important to note is when there is a health disparity based on one of these things, there are opportunities for us to look at each of these issues, particularly race, socioeconomic status, gender, age. We can come up with specific examples where we've seen some of those long-term historically linked issues around discrimination and exclusion. And health is one of those core pillars. Now, the burden of health disparities is important for you to know. And back in 2010, specifically, more than half of all Americans, so regardless of race, regardless of your age, regardless of your socioeconomic status, your religion, more than half of all Americans had at least one chronic condition. And almost a third had more than one. Now, chronic conditions, we attribute that to cardiovascular disease, issues like diabetes. Those are chronic conditions, chronic diseases. Those are long-term challenges. And in 2013, mortality data noted that the death rate per 100,000 population attributed to cardiovascular disease, it was actually higher in African-American male and females in comparison to their white counterparts. And there was a study done by NCBI, which is at the National Institute of Health. The prevalence of hypertension for persons that are over 25 was actually higher amongst those that had less than a high school education. And this is going to be really important to talk about when we move into social determinants of health. Where you live, where you work, where you worship, where you play, where you learn. All of these issues can affect your health outcomes. Now, I wanted to give you some context on cost. Now, 86% of healthcare spending is for patients with at least one or more chronic conditions, and over 71% of healthcare spending is for patients with multiple conditions. And what is that said in dollars and cents? At least 71 cents of every dollar of healthcare spending, it goes to treating an individual that has more than one chronic condition. And this accounts for specific healthcare issues and healthcare access, specifically clinician visits, home health visits, inpatient stays, prescription drugs. And these are some of the standard costs that go along with treating an individual who is living with more than one chronic condition. So if you consider 71 cents for every dollar, that is a large amount of money per dollar being spent on what we can call something that's potentially preventable. And that leads me into the discussion on social determinants of health. Now, when you hear this term, social determinants of health, it really is an opportunity for you to think about health beyond just health care in terms of clinical care. This is about conditions and environment, where you live, where you were born, where you work, where you play, where you worship, and even age that affects a range of health. You'll see functioning and also quality of life outcomes and risks. And we're going to talk a little bit more about this. The World Health Organization gathered a commission on social determinants of health. And you'll see the link here available to you. And the title of the report that they released back in 2008 was Closing the Gap in a Generation. And what they found were three major takeaways on really addressing the social determinants of health. And as we saw on the previous slide, this is about quality of life. This is not just about clinical care, but this is about all of those determinants. When we say determinants, we mean education. We mean issues around economics, poverty, housing. What are some of the key factors that need to be addressed in order to improve one's social determinants? So one, improving daily living conditions. An individual's living environment can and will affect their long-term health outcomes. If they're living in an environment that is highly polluted, there are issues long-term with asthma. They're living in an environment that has poor water quality. Those are going to be long-term health outcomes. And that is also normally connected to individuals that are living under the poverty level. Tackling the inequitable distribution of power, money, and resources. This is the systematic conversation we had earlier when we talked about health disparities. If you look at the distribution of resources in communities, the challenges have been there are at times systems that have been put into place where individuals that are in power select where resources go and don't go. When that happens, many communities, particularly communities that are most vulnerable, communities that have less power, are not able to access the resources needed, particularly around health and health care. And then the last thing is measuring and understanding the problem and assessing the impact of action. When this commission gathered, there was a push to ensure that we invest, we meaning the government, meaning state legislators, meaning state government, meaning businesses, meaning educational institutions, begin to look at the problem and assess the impact long-term in communities. And the impact of action means what can we do in our sectors to create living opportunities that can create health opportunities and create quality of life opportunities for constituents. Now, policymakers, what can you do? And quite frankly, does this really matter? Well, I want to close with a couple of slides. You hear us say a term today called health in all policies. And health in all policies is specifically a collaborative approach to improving the health of all people by incorporating health considerations into decision-making. As policymakers, this is an opportunity to be able to look at legislation from a multiple list of lenses. So for those of us that are in public health, we always start with the health lens or a health equity lens even. But what I would say to you is as you're thinking about your colleagues in your state houses and in your assemblies, there are opportunities to consider health in all of the work that you do. And I'm going to give you an example, the National Prevention Strategy. It actually comes and is chaired by the Office of the Surgeon General, where there's priorities put on prevention versus clinical care. And as we're prioritizing prevention, the intent is to integrate recommendations and actions that go across multiple settings that will improve the health of constituents and save lives. So the intent is to envision a society where every sector, transportation, housing, job sectors, business, educational sectors, schools, will work together to achieve better health for all Americans. Now, I want policymakers to see themselves as part of the solution. As a policymaker, you have a constituency. You have character because you ran for office. You coalesce because you bring people together. You're courageous, you're caring, and you're committed. And these C's are very integral in the work of reducing health disparities. Every policymaker has a constituency that they have been called on to represent. And in your constituency, there may be some differences in economic, socioeconomic status, differences in race, differences in religion, difference in age. Regardless of your constituency, it is important to consider what it takes to ensure that all of your members, all of your constituents have the same access to the same quality care. And also it's important for your constituents to have an even playing field to have a quality of life in your districts or in your counties. The character and coalescing means the opportunity for you as policymakers to build on those things that drive you and to bring people together. I think what's important to note for those of us that work in government, we understand that our methods to getting to the idea of having a healthy country may be different. But we have one thing all in common, is that we want for all of our constituents. And that's a courageous act to make. So it's important to look at being caring and committed to those opportunities that are in front of you, whether it is looking at fiscal policies, whether it's looking at human challenges that are happening right in your districts. You can see yourself as part of a solution. And your ultimate goal as a policymaker should be to achieve health equity. And what does that mean? It means attaining the highest level of health care for all people and then valuing everyone equally. And what's important to note in this definition is that this is an ongoing effort, and that's to address avoidable inequalities, historical and contemporary injustices, and ultimately eliminating health and healthcare disparities. There's a quote I wanted to share. Life's most urgent and persistent question is, what are you doing for others? And the most important thing today that I want to share with you, particularly those that are policymakers on the line, is that you are already ahead of the curve because you have chosen to serve. You have chosen to step into an office and to represent your constituency. Health disparities are alive and well. The data has shown that there are communities that have had challenges persistently and historically. But this can change with commitment from leaders like yourselves. And because you are persistent and urgent in looking at the most effective, and that means cost-effective as well as humanly effective, opportunities and strategies that can be put in place to improve the lives of the most vulnerable in your constituency. Here are some resources for you to have. The Closing the Gap in a Generation document. There is a Public Health Institute document called Health and All Policies. The National Prevention Strategy, which is available to download online. And I will also share that there's a new document that's been released by the National Academy of Sciences, formerly known as the Institute of Medicine, called Communities in Action, Pathways to Health Equity, released in 2017. It was my pleasure to speak with you today, and I hope that you will look at the best way to see yourself as a solution in eliminating health disparities. Thank you so much.
Thank you so much, Siobhan, for that introduction. We really appreciate it. And before we transition, I just want to remind participants that you can type any questions that you have into the Q&A box in the bottom left-hand corner of your screen, and we will field those to our presenters at the end. And now our next presenters from the state legislature and the State Department of Health, Senator Jim Abler and Sarah Hernandez, will talk about their experiences and efforts in Minnesota and Colorado, respectively. So with that, Senator Abler, I will turn it over to you.
Oh, well, thank you. I'm glad to be with you. I think I have 3 colorful, actually black and white slides. There's no Star Trek on mine, but it's a really important topic, and I'm happy to be a part of it, and I'm really happy that people have taken the time to take their lunch hours and talk about this. Minnesota has done quite a few things, and rather than go through everything that we've done, there's 3 slides, I think, of items that have been accomplished lately. Our focus has been particularly on the racial issues and just the disparities about that. In Minnesota, we have quite a diverse group of communities. We have a significant tribal community, and those health disparities are just downright poor. The Latinos and the African Americans and some of the new Americans that have come in, we have a lot of Somalis, and they're just not accustomed to engaging into the healthcare system like we have. Minnesota is quite advanced in caring about people. I'll just maybe kind of tick through these, how quick I should go through these slides, but just a bunch of things about autism and interpreters and quality and so we're trying hard, and to be practical, which is what I want to bring in, and I appreciate Siobhan's global picture there, but just kind of bring it down to the practical level. You really have to want it. There's so many obstacles that are in the way. I was surprised that the first slide that was up there, one of the national slides, showed that nearly half of the states hadn't done much of anything, and I can't believe they don't have health disparities that are going, and I want to encourage the people who are from one of those states to please jump in and make an effort. Sometimes it's just a matter of communication with the various community, and it doesn't have to be racial, but the racial are the ones that just have jumped out at me, because I think that it's just too bad that because of your gene history that you wind up being unhealthy, and it's really on our mind, and it's on the mind of a lot of us. The status quo is really one of the biggest obstacles, because we didn't ever do that before, or it's hard, and there is frankly racism that even in Minnesota, which people think of as a progressive, kind of a purple state, it's surprising how many barriers there are that just are kind of unspoken and kind of glass ceilings type. And then there's a fair amount of bias, and I intend to talk a bit about some of the foreign-trained doctors that we're trying to get going in Minnesota here. But the licensing boards and the communities of licensees really have gotten in the way of trying to do some of the very things that everybody in this call would want to accomplish. And so I'm glad you mentioned Dr. Ellinger, our Commissioner of Health. He has been very interested in this. And so as a senator and a former House member, it's really important that people at least attempt to cooperate. And, you know, an agency can go to war with the Senate, or the Senate can go to war with an agency and argue about how we're going to do it. But it really doesn't do a lot of good. At the end, the loser are the people you're trying to help. And trying to engage the various groups that are affected, including the providers as well as the entities you're trying to reach out to, a Latino group or a Somali group where you just want to target a certain part of town, or go to some of the greater Minnesota areas where there's clusters of new Americans. They really are amazing resources, and you know, for all of our genius, I don't know if you realize, when you become in the Senate, you become much more knowledgeable than the average human being. At least some of my contemporaries seem to think that. But if you just simply ask a question of the people you're trying to help, like, how would you help us get this service administered in your particular group, it's surprising how you can learn about that. I'm not sure if I'm that proud of it, but we're also the land of Jesse Ventura. If you remember, he shocked the world and became our governor for a while, and that was an interesting experience. But one thing that he was correct about is personal responsibility. And at some point, the government cannot do everything for people. They can't put them into a chair and dispense health care into them, and as hoping they'll just, you know, consume it and then be healthy. So how do you get a community that has different health habits or eating habits, some of which are very poor, or just not productive, and get them to change how they think about that? And you can pass a law, but you also want to engage these various groups, and it can make a huge difference about that. And then with the federal changes coming, money is going to be even more tight, and actually sometimes tight money makes you focus it better. And you know, if you are cleaning out your fridge to fit things together because you're out of room, if you take 2 pickle jars and pour them together, that's just called finding room for your pickles. Sometimes that's called a cut when you're running the Senate or a state. And we have to get away from polarizing, frenzied statements about that, and actually focus, in my mind, on the mission of serving these individuals, giving them all the chance to be as healthy as they might be. And I want to spend my last couple of minutes on talking about the efforts that we're right in the middle of now, trying to bring in some international medical graduates, foreign-trained doctors. And Minnesota has about 200 of them. And one of the things I think was on the list at the top of this page is International Medical Graduates Assistance Program. There was a specialized one. There was some very skilled clinicians that wanted to go to the Mayo Clinic, and so we passed a law to make that easier. There are some extremely skilled foreign-trained doctors who could go to work tomorrow if the system would let them. But instead, in Minnesota, they're required to do a 3-year residency, which makes no sense if you're a 20-year family doc. You don't need that kind of timing, that kind of work. You might need 6 months to get used to the nomenclature and the technology and the system that a particular clinic system works within. We've had a shocking amount of pushback from the medical community itself on allowing these individuals to come and to actually serve. And ironically, they're from everywhere, these 200 individuals, and there's certainly a bell curve, but the majority of them are capable of serving today in some of these underserved communities, the very ones we're so concerned about serving. And so we're working on building a bipartisan, bicameral coalition to try to find a way. Do you really care about these people that you say you care about, the underserved? Do you really care about them? Well, how about these doctors who could go to work tomorrow? Are we able to get them into a different track? And so that's currently on the front burner of my particular work. And so I just encourage the people that are not doing anything to do something and to create a community dialogue. And as you build kind of a consensus it doesn't take a lot of work to pass a consensus into law when the various departments, Department of Health or the governor or whomever, and the House and the Senate of your various states agree on the mission. And my final thought will be, it's all about the mission. It's focusing on the individual and realizing what chance you can do, what opportunity you can help them have to actually have the life that we take for granted in some of our in our daily walks. And the new Americans in particular, they're working on language and housing, and they just want to be secure, and they want a chance for their kids to enjoy some of the very same things that we've come just to kind of count on. And so the payoff in that, never mind the savings in state budgets and all those other costs, but just the value of life that goes into that, to me is profound and compels me to work on this every day. So I think I'll let it go at that, and we'll stand for questions at the end. Thank you.
Great. Thank you so much, Senator. And now I'm going to turn the floor over to Sarah Hernandez to tell us a little bit more about what is underway in Colorado. So Sarah, I will turn it over to you.
Thanks very much, Kate. Good morning, good afternoon, everyone. Thank you for being part of today's webinar. As Kate mentioned, I work at the State Health Department in Colorado, and specifically I work in the Office of Health Equity. So just to give you a bit of background on our office, the Office of Health Disparities and our Health Equity Commission were codified in statute through the Senate bill. I have the number up on the slide here if anyone is curious. That happened back in May of 2007. But then in 2013, as a result of a House bill, we actually ended up changing the name of our office to the Office of Health Equity, and it was expanded to serve lesbian, gay, bisexual, and transgender populations, as well as aging populations, folks with differing physical abilities, low socioeconomic status, and geographic populations. Our General Assembly declared that this reflected the recent advancements in the field of health by broadening the scope of the office to include these other determinants. And our earlier speaker, Siobhan, spoke about those types of determinants. Before I go on, I also want to establish some of the benefits of embedding equity into a health department and state governments in general. Aside from a moral imperative, research shows that more equitable regions experience stronger, more sustained growth. There's also research showing that lower economic inequality results in better health outcomes for everyone. And lastly, researchers predict that health equity would lead to significant economic benefits from reductions in healthcare spending and loss of productivity. And I think that the Senator's points, sort of hit on all of those as well. I also wanted to mention that in addition to the Office of Health Equity in Colorado, we also have a Health Equity and Environmental Justice Collaborative, which is housed here at the Health Department as well, but it's comprised of volunteers from every division of our Health Department. And that has actually helped us increase buy-in in every pocket of our department, and we're one of the largest state agencies in Colorado, so that's been great. Okay, so I want to thank ASKO for mentioning the triple aim of health equity. I just wanted to really mention that, advancing health equity and environmental justice is a priority that's called out in our department strategic plan. About a year ago, our department also created an internal policy empowering staff to incorporate equity and justice into their day-to-day work. So we're really looking at how to embed it into the core functions of our department and taking it to the mission of our agency. So the policy also calls for all of our staff to participate in a Health Equity and Environmental Justice 101 within a year. And so now that it's actually been a year as of this Friday, we're seeing successes partially by using this same triple aim that ASKO provided. It's a good way to organize people, narrative, and resources. But beyond the framework, we've really had to have some deep conversations about what does it mean to actually operationalize this pyramid. So here in the Office of Health Equity in Colorado, how we're operationalizing that pyramid is we're categorized into 3 C's. And I appreciated the Siobhan's earlier slide on seeing yourself as part of the solution, particularly because we like to think of the C's as well, but I think the C's that I have on this slide are just a little bit different or build upon what Siobhan was saying. So coaching, connecting, and changing systems and policies. I'm going to talk a little bit about each of these. By coaching, I'm referring to a set of one-on-one sessions or working with groups here and programs at our health department as well as across state government. Also specifically, I wanted to mention that we developed a suite of tools on operationalizing health equity. And a little bit of background there is that we were hearing from department staff that they really value the concept of health equity, but they wanted to go deeper as far as embedding it into the core functions of their work and kind of taking it from a noun and something that can sometimes be a nebulous concept to really turning it into action. How do you take it from a noun to a verb? And so those suite of tools are intentionally very brief. We essentially did a lit review on a handful of topics such as measuring equity work and framing data, hiring and retaining a diverse workforce. So we really were trying to get nuts and bolts about the work. And those tools are available on our website. We also work in partnership with community, which I'll be going into more depth in a second. But as far as changing systems and policies, we implement a health and all policies approach, which Siobhan mentioned earlier. But it's a multidisciplinary way to incorporate health and equity into decision making. And it can look a lot of different ways. It looks different in every single state and jurisdiction, but it can incorporate the use of aligned data, funding, and resources. And it's an important step to addressing those upstream determinants of health, those socioeconomic factors that are creating health. And so now what we're doing in the Office of Health Equity is seeking cross-disciplinary projects with other state agencies to address those upstream determinants of health. We're accustomed to working with other state agencies, but I would say the difference now with health and all policies and using this approach is that it's very, very intentional. We also recognize that valid and reliable data should be used to guide decision making, and that it can also be a mechanism to begin conversations with those partners across other sectors and outside of traditional health. And so to understand root causes and determine resource allocation, our staff will also be working on developing a statewide equity profile over the next year with indicators related to well-being and opportunity. And then we also administer a Health Disparities Grants program with state funding. So we're intentionally building partnerships with groups working on issues such as housing, transportation, and economic opportunity, to name a few. And what we're hoping to do is to identify win-win solutions and maximize the impact of programs and policies across the state to advance equity and community health. So I'm going to go into a little bit more detail today on 3 specific strategies that we're using. Community engagement, incorporating an equity lens into decision making, and then data. All right, so here in the Office of Health Equity in Colorado, community engagement is a top priority. Not only is it part of the triple aim of health equity, that pyramid, but it's also an important part of sustainable decision making. This slide image comes from the International Association for Public Participation, and it's a great visual demonstrating that there are 4 parts to long-lasting decision-making. So from a smart planning standpoint, decisions should not only make financial sense, be logistically feasible and environmentally compatible, but there should also be wide acceptance from the public. For this reason, we have 1 full-time employee dedicated to providing training and technical assistance to department employees on meaningful community engagement methods. This employee is also charged with building and maintaining relationships with community leaders. Our aim is to build trust with our community partners so that they can be meaningfully involved in decision-making processes. This can look a lot of different ways, but it ranges from community representation on boards and commissions to using public participation methods such as town halls. And we're also looking at how to involve community representatives in our data acquisition methods. We're actually in the process of hiring a social epidemiologist to help us kind of pilot that process out. All right, so now I want to talk about incorporating equity, an equity lens into decision making. which is basically understanding how a particular decision will affect different populations or demographics. So this is important not just from an equity perspective, but also from a cost savings perspective. So for a hypothetical example, let's say that we were given $5 million from the state legislature to increase affordable housing in Colorado. We could try to increase affordable housing in general, which is terrific, but what it could do is unintentionally increase inequities between groups. So what I mean by that is that certain demographics may already be better off, and if they receive additional housing options, they end up doing even better. Applying an equity lens means that we take a deep look at our data and learn which demographics stand to benefit the most from receiving additional housing options. And in this way, we are intentionally decreasing a disparity. We're trying to shrink that gap between groups. And as I mentioned a few slides back, research demonstrates that decreasing inequities yields cost savings and sustainability to the state down the road. So it's in our best interest to try and decrease these disparities. And also, I use the example of affordable housing because housing has such important implications for the public's health. And again, that goes back to those social determinants of health that have been mentioned a few times throughout this webinar. So this is the type of project that we in the Office of Health Equity would intentionally try to partner on to further our health and all policies approach, because it's important to work across all of our government agencies, and particularly with those outside of traditional health. So this particular strategy for us is still a work in progress, but one way that we're trying to diffuse it is by building staff capacity. And that's partially where that Health Equity Environmental Justice 101 comes into play, where I mentioned that earlier in the call, that all of our staff have to have the opportunity to participate in their first year of employment. So as a result of that, all of our staff should at minimum be able to identify the difference between equity and equality. And then I've just mentioned the efforts to include community representatives in decision making as a means for sustainable decisions. All right, and the last item that I'm going to go into here is on using data. I mentioned that health equity and environmental justice are priorities in our department's strategic plan. And because of that, there are performance measures tied to the priority that are regularly examined. For example, last year an activity that was regularly measured was the number of department employees who had participated in that Health Equity Environmental Justice 101. And over this next year, one of the activities that we're going to be measuring is embedding a tool to help our staff apply equity in their decision-making processes, as well as monitoring implementation of other health equity and environmental justice guidance documents. The other type of data I want to talk about is population-level data. So as part of that triple aim of health equity, the pyramid, we're working to expand the narrative of what creates health. So as the pie chart on this slide demonstrates, the biggest predictor of health are socioeconomic factors. This means that we need to incorporate data from sectors outside of traditional health, such as transportation and education. And I briefly mentioned this, but over the course of the next year, we're going to be dedicating resources to this by developing a statewide equity profile aimed at spurring action on the social determinants of health. That process will heavily involve community leaders at every stage as part of an advisory team. The advisory team will also include representatives from sectors outside of traditional health, so folks from housing, transportation, that kind of thing. And this is an important part of our health and all policies approach because the profile will serve partners in sectors both within and outside of health, and will aid in relationship building and problem solving across sectors. And it will also hopefully ease the process of data sharing across state agencies because the idea is that the profile will be benefiting all of us. Okay, and then one last item before I wrap up is that being intentional about how we frame population health data is really important. Our department processes a large amount of data, as I'm sure is similar to other state health departments. And the common narrative is that individual behaviors are what create health. But again, referring to the pie chart above, we know that there are structural factors related to socioeconomic determinants that play a greater role in health outcomes. And for that reason, our department adopted a statement on structural inequity. This statement acknowledges this, as well as reducing health disparities through systems change, will help improve opportunities for all Coloradans. And that statement now accompanies all of our data products coming from the department and is available on the Colorado Office of Health Equity website for anyone who's interested. And here I actually have, if anyone looking to connect with us, we have a monthly newsletter where we try to disseminate discussion topics and resources as well as social media sites. And in closing, I just want to share for any other health departments who are working to advance equity and looking to do more. I think as far as our lessons learned, we've learned that this work takes time. We're changing systems and processes, and I think it was the senator who mentioned changing status quo, and that's very, very true. So I think just being patient with the process is really important. And that said, progress happens a little bit at a time. So what's really important is just to try something. Action, whether successful or not, spurs momentum, and you end up learning something. So don't let perfect be the enemy of the good, and don't be afraid to fall forward. And with that, Kate, I'll turn it back to you. Thank you very much.
Wonderful. Thank you so much, Sarah, and thank you to all three of our presenters for those great presentations. And now we're going to move into the question and answer and discussion portion of the webinar. So I already have some questions for you all, and if other folks have questions, please type them into the Q&A box in the bottom left-hand side of your screen, and I will post them to our speakers. So Sarah, I think you're not quite off the hook yet. We have one question for you is if you can share a little bit more about your suite of tools that you use to operationalize health equity work. And do those tools help you prioritize your efforts, and what data sources do they incorporate?
Yeah, that's a good question. I think that it does help us prioritize our efforts. One tool in particular, actually I want to give a shout out to Minnesota Department of Health because my understanding was that they were using a set of questions to kind of help guide their decision making. And so we borrowed that set of questions and kind of did some focus groups here in Colorado and tweaked them. But the idea there is that they are helping to guide priorities, and we call them checking assumptions because they're intended to help us think through our decisions and how inequities may be unintentionally being perpetuated. As far as data sources, so what we did with each of the topics is we essentially scoured the internet for all of the existing resources that we could find on the given topic, and then we also conducted informational interviews with folks across the country actually who we felt had lots of advice and insight to lend on the particular topic. And from that, we tried to come up with the most salient interviews, salient points, sort of the high-level Cliff Notes version, if you will, of that particular topic. Because what we were hearing from our staff is, there's so many resources out there, and I feel too overwhelmed to read all of them, and I don't have time to read a 50-page document. Can you just give me, a one-page handout on this topic? And so most of the tools are either 2 to 6 pages long, but we were very intentionally trying to keep the tools brief and concise. And so each of the tools has a list of citations and resources that we use to develop them, because we still want to encourage folks to go deeper as they have time and as their work allows, and if they're working on a specific project, for example, where it makes sense. And I should mention that we have some tools up on our website currently, but it's a work in progress, and so our plan is to every month or two add an additional tool, because it's sort of a continuous work in progress. So I hope that answers the question.
Yeah, and Sarah, I think this speaks to that too, but can you share the questions that you in Minnesota used as a guide? Are those on the website?
They are, yeah. That one is up on the website, and it's called Checking Assumptions. Our website, if you click on the subscribe on the slide, there's a hyperlink to our website, and so it'll take you there. Just look for the Suite of Tools tab.
Great. And let's see, and then Senator Abler, I have a couple questions for you related to the international medical graduates that Minnesota is bringing in. I'm combining two people's questions. So one is around whether those folks are more likely to specialize in family medicine and other preventive-focused specialties, and then also if they reflect the demographics of the new immigrants that are migrating to Minnesota.
The answer is probably yes on both counts, but some of them are are surgeons, and some are very advanced in what they would bring, and they some have gotten to residencies or been close, and they're so knowledgeable they wind up tutoring their mentors. But there is a high amount of family practice interest on those groups, and they're very reflective of the groups that they would like to serve.
The questions are rolling in. I'm trying to keep track of them all.
Oh, yeah. I could ramble longer, but I thought I'd be.
Right. No, I appreciate it. And then also, I guess, Sarah, going back to you, there was a question about whether you felt that your office benefited from starting out with a focus on racial and ethnic disparities.
That's a good question, and to be completely honest, I wasn't with the office when it was titled the Office of Health Disparities. But my gut reaction to that question is, it was important to raise awareness about racial disparities, and sometimes the topic can be uncomfortable to talk about. So I do think that it may have poised our office for this work differently than if it had been called the Office of Health Equity right from the start. But that said, I think broadening the name to serve any population who's experiencing inequities is also really important, and especially from a relationship building standpoint.
And Siobhan, I have someone wondering if you have the new information, I think it was a report being released this year, if you have the site that, a website link or something where folks can find that pretty easily.
Yes, so the National Academy of Sciences, which is formerly called the IOM, the Institute of Medicine, there is now a new report that was released on health equity, and it's called Community-Based Solutions to Promote Health Equity. So if you go to National Academies, all one word, .org, and you type in Communities in Action, Pathways to Health Equity, you can actually download the document.
Great. Thank you. All right, and Senator Abler, I've got another question for you about whether some of the, I believe the question is asking whether some of the pushback on the recruiting international graduates is because doctors and residents are leaving. I assume the state or the areas where you need folks, or and also do you have a partnership with hospitals and colleges to encourage doctors to stay? So I think it's around recruitment and kind of retention of the providers you have.
Well, there's two kinds of doctor issues. The retention and getting people to want to go to greater Minnesota, in our case, is a challenge because everything, the metro areas where people seem to like to live. We have some residencies we're trying to pay for that people would then go spend at least 5 years out in some small town. And that's a challenge because they just seem to spring back to the metro. But the idea is that if you can get them to spend some time, they might actually get to really appreciate the life out there, which is a unique and a very good lifestyle. So that's just the more homegrown doctors part. The issue on the foreign trained docs, I'm not sure if that was part of your question, but the issue there is they're already here. They would like to work. Recruiting them is no problem. Getting them into the right track and treated in a fair way is the problem. Because they could go to work tomorrow, many of these. 80% could go to work tomorrow. 20% need some remediation or something else.
Mm-hmm. Great. And then I have a longer question I'm going to try and parse down for you all, but I think, and it's a little political, but but in terms of kind of looking at what's happening, Senator Abler, I think you referenced it, but looking at what's happening in Congress and kind of the changes being debated in regards to healthcare these days, kind of are there any things that states can do now, regardless, I guess, is kind of what the question is asking to me, but what can states do to kind of ensure that they're kind of promoting health equity or helping reduce disparities, even as we debate these things around coverage and things like that and access?
Who do you want to start with?
You can start.
Okay. Well, we have a lot of things we can do. A lot of the proposed changes, which are massive and frightening to a lot of us, and there's a lot of frenzy about it, though, too. I'm trying to get the facts figured out, what's being truly proposed, and it seems like growth is being limited. And so back to my pickle example, if we can find ways to do the best work we can do with the dollars that we have, and if the states are given flexibility to do stuff in their own way with more moderate amounts of dollars, a lot of good things can happen. And so just a short idea is that the feds limit us in so many ways. And then our very careful federal compliance staff says, oh no, you can't do that, which means they think maybe we couldn't do that. And actually, the whole national system, state by state, is begging for innovation and experimentation. And I don't know how much the states do, but I think we should do more of cherry-picking good ideas that worked well in Wisconsin or Colorado or Minnesota or somewhere, and just kind of implement those as our policies. And there's not enough of that.
Sarah or Siobhan, I don't know if you have anything to add to that question.
I'm sorry, I was on mute. So what I would just say, from my standpoint as a member of the staff of the Surgeon General's office, what's most important for us is that there is something done as it relates to healthcare being reformed. That is a little bit more of a political question from our standpoint, but I would say that we stand on the basis of prevention and health equity. So our goal is to ensure that there is a focus on prevention, there's a focus on actually long-term savings, where we can focus on prevention care versus sick care. So that's, I think, where I'll comment there.
Great. Thank you. And we are actually nearing the top of the hour, so unfortunately I'm going to have to cut off our discussion and questions here, but I want to thank everyone for your questions and your participation in the webinar, and I want to thank our presenters again, Siobhan Arline-Bradley, Senator Jim Abler, and Sarah Hernandez, and also our partners at the Association of State and Territorial Health Officials and the Office of Minority Health. I do want to remind you all that an archived copy of this webinar will be available on NCSL's website on the link that's on the bottom of the slide. And I know there are a few questions about the link from you, Siobhan, so I'll be sure and include that on that web page, as well as NCSL's forthcoming brief. As soon as that's out, I will post it to that page as well, so all the folks here can access this and share it with your colleagues. And I also, before I know folks jump off at the top of the hour, so I do want to just highlight that as we close this down, an evaluation survey will pop up on your computer screen, and your feedback is very helpful to us.